This is Audible Bleeding, the vascular surgery podcast. We're here to help you keep your finger on the pulse.
Welcome to our first Audible Bleeding VSITE review. Today we have myself, Kevin, Adam, and Nicole on the line, and we are going to take you through a cerebrovascular disease review for the VSITE. This is intended to be board review material. It's based on some of the newest clinical guidelines, but most of the answers are geared to get you through the VSITE. So keep that in mind when listening, and feel free to email us if you have other topics you want to hear or suggestions for the VSITE. So Adam, let's just get this started. Something we hear about a lot and is frequently tested is crescendo TIAs. What does this mean, as this is one of our few emergent indications for carotid?
The definition of crescendo TIAs is really frequent repetitive neurologic attacks without complete resolution, usually within 24 hours, that produce the same deficit but don't progressively deteriorate. If there's progressive deterioration of the neurologic deficit, then that's actually a stroke in evolution and not a crescendo TIA.
Yeah, and that's the key point, is if there's progressive deterioration between the TIAs, it's actually a stroke in evolution, which is different than crescendo TIAs. So Nicole, who needs to be screened in the general population for carotid disease?
Right. So when we're talking about screening, we are discussing asymptomatic patients. While there is a role for screening, we don't generally just screen the entire population, as that's not indicated. But, asymptomatic patients do have a risk of stroke. In fact, only 15% of stroke victims have had a warning TIA before they have their stroke. One thing that people commonly use as kind of a prequel to screening is checking for a neck bruit on exam. But it's important to know that if a patient does not have a neck bruit, it doesn't exclude the possibility of a significant carotid bifurcation lesion. And in terms of choosing which patients actually warrant screening with an ultrasound, in patients who are over 65 years old and have clinically significant peripheral vascular disease and a history of one or more of the following risk factors: coronary artery disease, smoking, or hypercholesterolemia, those patients should be considered for screening. And in general, the more of those risk factors that are present, the higher the yield of screening.
Okay, great. So if they're older than 65 and they have one of those three risk factors, coronary artery disease, smoking, or hypercholesterol, they qualify for screening. The more risk factors, the higher yield the screening test will be. So if you have a 50-year-old patient that comes in your office without significant risk factors or history, probably doesn't need the screening ultrasound, not going to be very sensitive. So thank you for that overview, Nicole. So Adam, let's just dive in. When we're getting these screening ultrasounds, how do we interpret them? This is very high yield in both our daily clinical practice and on the VSITE.
Yeah, so there's a number of things that we look for on the ultrasound that correlate with stenosis. And ultrasound really has been found to be the most cost-effective way to screen and lowest risk, least invasive for the patient. So they look for really the peak systolic velocity of greater than 230 correlates with a 70 to 99% stenosis of the ICA. And then this also then correlates with an end diastolic velocity of greater than 100 or a ratio greater than 4. And then a peak systolic velocity of 125 to 229 centimeters per second correlates with a stenosis of 50 to 69%. And that's also an end diastolic velocity of 40 to 100 or ratio of 2 to 4.
Can you explain that ratio to me?
It's the ratio of the peak systolic velocity in the internal over the peak systolic velocity in the common carotid. Because when you have a patient who has, say, a contralateral occlusion, sometimes you're going to see elevated internal carotid artery velocities on the side that's open, but they may not correlate with a significant stenosis in that setting because the patient may be getting all of their cerebral circulation from the one side. And so you actually have to look at the ratio of the internal to the common in order to evaluate that in that setting.
I think the critical thing you mentioned is I know when we're evaluating asymptomatic patients in clinic, we want to see that end diastolic velocity greater than 140. That is what is most predictive of a greater than 80% stenosis. So sometimes you'll see a lot of high systolic velocities, on these patients, but really it's the diastolic velocity that's going to be predictive. So you really want to see that end diastolic velocity greater than 140 for patients that have asymptomatic disease. The carotid ultrasound is not very sensitive for 50 to 70% stenosis. A negative ultrasound in symptomatic patients necessitates additional imaging. So if you have a patient that had a stroke, your ultrasound reads, relatively low stenosis, then you can use some other modalities to evaluate their carotids. It's not as predictive in that setting. So Nicole, there are a few other ways. We know that we can actually go to the operating room just with the ultrasound if it's the story and everything fits. But can you tell us some of the other options and the pros and cons of these?
So CT angiogram and MR angiogram are two of the most frequently used imaging modalities. Invasive cerebral angiogram, I think, is still considered the gold standard of imaging, but it's not used very frequently just as a screening or preoperative test because it's invasive and carries a risk of stroke. But in patients, as you mentioned, Kevin, where their clinical picture doesn't match what we're seeing on ultrasound, often a CTA or an MRA is obtained in order to try to clarify what degree of stenosis the patient has in their carotid.
Definitely. And so, I think most people nowadays are using CTA, but if there's some reason they can't get that, or your institution, an MRA, the nice thing about the MRA is you don't have any contrast administered. There's some people that can analyze the plaque morphology a little bit better with the MRA that you can't quite with the CTA. Every institution is a little bit different. I think a lot of people are getting CTAs along with their ultrasounds before going to the OR for operative planning, especially if you're talking about TCAR or one of those modalities, or carotid stenting, which then it was pretty much a requirement. Now, medical management. I'll talk us through some of the important medical management. It's still just like on the ABSITE and everywhere else. When you have a patient that has carotid artery disease that is asymptomatic, you want to start with medical therapy first. The correct answer is not to go to the operating room unless they meet certain criteria. But what are our current medical therapies we need to offer these patients? So treatment of hypertension is the first. You want to have the blood pressures less than 140/90. Obviously start with lifestyle interventions and move on to antihypertensives. Treatment of diabetes is extremely critical. Glucose control, aiming for an A1C of less than 7 is recommended to reduce vascular disease. And then, of course, treating our lipid abnormalities. The risk of stroke is decreased 15% for every 10% reduction in serum LDL with patients with known coronary artery disease. So the kind of goals for statins are you want to have targeting the LDL of 100 or less to help reduce their risk of stroke. And then if they're extremely high risk, you want to get their LDL less than 70. And these are things you'll be working with your primary care doctors, to help with. Obviously, smoking cessation is critical in these patients, and antithrombotic therapy is controversial. There's no evidence to suggest that any antiplatelet agent over aspirin has any improved benefit in asymptomatic patients, but many times you'll see some of these patients placed on Plavix. So hypertension, diabetes, your statins, smoking cessation, and aspirin are the answers that you're going to answer when it comes for medical management. So Nicole, what are the recommendations on operating on a patient after a stroke? How long should we wait? Should we take them right to the operating room? What are the best timing for that?
Well, in the past, we used to wait several weeks, but newer data shows that it's actually safe to take a patient to the operating room sooner than we used to. In general, we aim to take a patient who has a fixed neurologic deficit to the OR within 2 weeks for a carotid endarterectomy. And that's preferable than waiting longer than 2 weeks.
The concern is always you're not going to help this current stroke, but how do you prevent them from having another stroke in that time period? And so I think some of the earlier recommendations, they were showing that there was a significant risk of having a stroke in that time period. And so you're kind of weighing the risk of converting an ischemic stroke to a hemorrhagic stroke versus preventing further ischemic stroke. So how about for, like we were talking about earlier, Adam gave us that good definition of a stroke in evolution versus a crescendo TIA, whereas a stroke in evolution is you're having recurrent symptoms that are worsening, whereas a crescendo TIA is repetitive transient ischemia with improvement between events without worsening of the overall symptoms. What are these kind of known for in vascular surgery as far as indications for carotid surgery?
These are considered the only emergent indications for a carotid endarterectomy.
Yeah, definitely. And so, if they give you the patient on the test that's having symptoms like this is when you'd want to consider an emergent carotid endarterectomy to prevent further. And this is where clinical exam and everything really comes into your clinical decision making here.
And also evaluating the imaging findings to see if there is what you would consider a surgically correctable lesion that you believe is contributing to the patient's neurologic presentation.
Absolutely. And I think seeing something like an ulcerated plaque, something that kind of fits the story of them having these Crescendo TIAs. So just, for board answers, Crescendo TIAs, stroke and evolution, know the differences between the two and know that they're both emergent indications for carotid endarterectomy. Okay, so let's get to the fun stuff, actually performing the surgery. Nicole, what are the two ways of performing a carotid endarterectomy?
So you can either make a longitudinal arteriotomy or do an aversion approach.
Yep. And so, you can do the longitudinal incision, which I think most people are most familiar with, and you perform a patchy angioplasty on it to prevent any stenosis when you close it, versus the eversion where you actually divide the carotid artery, evert the plaque out, and then perform a primary anastomosis. We'll talk about a little bit of the pluses and minuses of these. It really comes down to what people prefer and what technique they use. There's really no benefit to either one. So one of the biggest concerns in performing a carotid endarterectomy is, whether you need to shunt or not to shunt during these cases. So there's a few techniques that we use. Every institution is different, and there's not a whole lot of level 1 evidence to show that one way is better than another. So I'll just run through the three of those. The first one that you'll see is patients that get carotid endarterectomies can actually do it awake with a great anesthesiologist that can perform a cervical block and some sedation. You can have the patient awake and test clamp the carotid artery and have the patient squeeze the, whether it's a rubber ducky in the contralateral arm. And this is kind of what is thought to be one of the gold standards of testing whether a patient needs to shunt. So obviously, if they have weakness or inability to squeeze the rubber ducky or have any symptoms, you then would shunt the patient. This is shown to be a successful method, but it actually does not reduce the MI rate, which is a problem with carotid endarterectomies. And they thought, if you're not putting them under general anesthesia, there might be a lower MI rate, but actually in the bigger studies, it does not show that local anesthesia is any better at that. One kind of very common method is the stump pressures. And so then you just hook up an A line, you clamp the inflow into the internal carotid artery, and you place a butterfly needle into the internal carotid artery distal to that clamp. And this is helping you determine the back pressure. And so generally, if the stump pressure is greater than 40 millimeters of mercury, it's thought to be that there's adequate collateral circulation to the brain, and so you can proceed with the surgery. If less than 40 millimeters, you want to place a shunt. And then kind of one that they use a lot up here in New York is the EEG neuromonitoring. So the EEG tech places neuromonitoring, and it's actually monitored both by an intraoperative tech and a neurologist remotely. We clamp the internal carotid artery for 3 minutes with the neuromonitoring on. And if they say that there is no deficits in the EEG, then we proceed with the surgery. If there are any deficits, obviously, we remove the clamp, allow normalization of the EEG, then place the shunt. And then there's quite a few surgeons that prefer to do non-selective shunting where they just shunt all carotids, and this is also quite common. So now that we know our methods of monitoring during a carotid, Nicole, if you can take us through what are the techniques to reach internal carotid lesions that are high. And I've heard this is very high yield for the VSITE. They want to take you through these tough situations. Also very common PIMP questions in the OR. And this is why it's very important to know your preoperative imaging to see at what level your bifurcation is at.
Yeah, so this is one of the reasons why cross-sectional imaging can be very helpful in terms of planning for an operation, because it gives you a sense of how high up the bifurcation is. And you can evaluate that based on the level of the cervical vertebrae. And if you go into an operation knowing that you've got a high bifurcation that you're going to need to access pretty far up into the neck, some of the techniques you can use for that is have your anesthesiologist do a nasotracheal intubation, which allows the patient's mouth to be closed, and then that gives you a few extra, at least millimeters, in terms of having the jaw out of your way and getting higher up in the neck. You can also ask your ENT colleagues to help sublux the mandible in order to help move the jaw out of the way. And then the posterior belly of the digastric muscle can be transected to improve your exposure to high lesions. Although when you're doing this, you have to be extremely careful not to injure the glossopharyngeal nerve, which is a much smaller nerve than the other nerves that you commonly visualize during the operation. So, it has to be identified and protected carefully. And then finally, there's also the option of a styloidectomy, where you actually remove the styloid process in order to improve the exposure high up in the neck.
So I think that's a great review. I think the first thing you would probably do if you're going into one of these cases, you'd probably start with the nasotracheal intubation. The posterior belly of the digastric, if you're very careful, can be divided relatively safely. And then I think styloidectomy would be your next step. And then if all of those are not helping and you can't reach this lesion and you can't do a TCAR or some sort of carotid stenting, you could talk about subluxing the mandible. All very important methods to have in your toolkit. So Nicole, sometimes we deal with patients that have a kinked internal carotid artery. This is the one indication to do this type of carotid endarterectomy. What is that?
That would be an eversion endarterectomy, because by transecting the internal carotid, you can actually reduce the redundancy when you reanastomose. And I've also read that some people transect the common and actually maybe remove a piece of the common and then mobilize the bifurcation inferiorly and then reanastomose the common.
Definitely. And so this is the only time, if they ask you which is better, patch endarterectomy versus eversion endarterectomy, and there's no difference except when there's a kinked internal. It gives you some ability to reconstruct the kind of length of the internal carotid artery. So of course, we've learned these many times over, but always have to kind of relearn them. At least I'll speak for myself. It's the nerve injuries in carotid endarterectomies. So we'll just go through them one by one, Nicole. Let's talk about the hypoglossal. Where do we identify this and what injury do we see?
So the hypoglossal nerve passes above the bifurcation, kind of on the side of the external carotid artery. And usually you see it kind of hanging down as like sort of a loop into your field. According to the literature, it's the most commonly injured cranial nerve during carotid endarterectomy. And if it is injured, you can see tongue deviation to the side of the injury.
Absolutely. It's one of the first things we check when they wake up. All right, we've already discussed this one a little bit, but this can be quite devastating. What do you see? How do you identify the glossopharyngeal and what kind of injury do you see there?
So the glossopharyngeal, oftentimes you don't see it unless you're going after a high lesion, but it is located under the digastric muscle, and if it's injured, it can lead to difficulty swallowing, high aspiration risk, and it can be pretty devastating injury.
Yes. So this is the glossopharyngeal underneath the digastric. Sometimes they say it actually runs in the muscles of the digastric, which makes it even more difficult to identify. So really high suspicion when operating around that. And, sometimes these patients will need a peg tube and a trach to survive this sort of injury. So very devastating. Adam, can you take us through the vagus injuries and what we can see in that?
Yeah, so the vagus, it runs adjacent and lateral to the carotid, and the injury often occurs during the carotid clamping. This can then result in hoarseness afterwards because of the recurrent laryngeal nerve, which is a branch of the vagus. It's actually a contraindication sometimes for doing a carotid when someone has paralysis of the contralateral vocal cord, and might be an indication to do a stent procedure instead of an open carotid endarterectomy.
And then, Nicole, if you can close this out with the marginal mandibular nerve.
So the marginal mandibular nerve is a branch of the facial nerve, and it's kind of located underneath the mandible. It's often a retraction injury, and it can lead to the corner of the lip on the ipsilateral side drooping and can be confused with a significant neurodeficit following the case.
So post-op complications, this is extremely high yield. I think diagnosing and deciding when to go to the operating room is what you're going to see on the VSITE, but then also managing the post-operative complications. And this is also likely pertinent for the vascular oral boards. So Adam, the dreaded situation, you finish your carotid endarterectomy, you wake the patient up and you note some neurodeficits, contralateral weakness, whatever it may be. What's your first step? You're still in the operating room.
Yeah, so I think it's important to, really do a thorough neurologic exam and confirm that it's in an area that might be associated with the carotid distribution. If it's in the OR, you perform a duplex. If normal, then you would actually open the wound and do a cerebral angiogram. However, then if it's in the PACU or on the floor after the surgery, then many would consider a CTA to be first versus a duplex.
Wherever you are, you have two things you're concerned about. You're concerned about an intimal flap causing thrombosis, or you're concerned about an embolic event causing a stroke. So the first thing you're going to do is look for the thing that you can surgically correct, which is the thrombosis, an intimal flap causing a thrombosis of your carotid artery. And this can be identified with the duplex. Unfortunately, if your duplex is negative, that is when you're in the operating room. That's why when you shoot the cerebral angiogram to identify if there is an embolic event that could potentially be intervened on by neurointerventional. And so those are kind of your go-tos. If they're already on the floor, you could start with the duplex, but it's likely just as quick to get them to the CTA scanner, and you can answer both questions at the same time. Do they have a thrombosis? And B, do they have any embolic event? So these are devastating situations. You want to solve the problem quick, determine thrombosis versus embolic, and treat them appropriately. Okay, one thing that's tested commonly, thankfully we don't see it too often, is the hyperperfusion syndrome.
Characterized by ipsilateral headache, hypertension, potentially seizures, and then focal neurologic deficits, likely in the distribution of the carotid.
Can you discuss kind of what patients are at high risk for this and how to prevent it?
Yeah, so post-operatively, one of the most important aspects of the management of these patients is to make sure that they are normotensive. If patients have uncontrolled hypertension post-op, they're at risk for hyperperfusion syndrome. So the SVS guidelines recommend strict blood pressure control after a carotid endarterectomy of less than 140/80. And
patients that have uncontrolled hypertension before the operation are at higher risk for this problem. And really the only thing to do in these patients is to control their hypertension. And one thing I have learned is a lot of times this isn't immediately post-operatively. This can be 2-3 days out from surgery. And in many of these patients, you just admit them to the ICU and do blood pressure control and symptomatic control and make sure that you don't have any embolic disease or some other complication that this is masquerading as. But yeah, a lot of times this does happen a little further out. So it's something to be aware of. That's why blood pressure control is important, and it can be quite concerning complication. So we've talked about some of the acute complications of a carotid endarterectomy. We finished the case, they got discharged, did well. What do you recommend for follow-up ultrasound? And what do we define as restenosis of these patients?
So all of these patients should have a follow-up duplex ultrasound of the bilateral carotids at 30 days post-op. It's important not to forget that their contralateral carotid is at risk for developing a stenosis, and so that should be included in their post-op surveillance as well. And if on that ultrasound greater than 50% stenosis is picked up, these patients require further imaging.
So, Nicole, one thing to always keep in mind is another technique to treat carotid artery disease. It's carotid artery stenting, and we also have TCAR, which we'll talk about a little bit later. Can you just tell us the sort of general principles of which patients you'd consider for carotid artery stenting?
Carotid artery stenting is used in symptomatic patients. It's quite controversial in asymptomatic patients and not currently reimbursable in them. So in a symptomatic patient who has greater than 50% stenosis, but is a poor candidate for a carotid endarterectomy due to severe uncorrectable medical comorbidities, and anatomic considerations such as a history of an ipsilateral neck dissection or radiation therapy, a contralateral vocal cord paralysis, or a lesion that extends very high into the neck or very proximally. In general, people say proximal to the clavicle or distal to C2. Those patients may be considered candidates for carotid artery stenting.
I think those are the important points to know. And Adam, can you just kind of give us how TCAR fits into this?
The transcarotid stenting, which utilizes flow reversal, is thought to provide better embolic protection than the distal filter that's used during traditional transfemoral carotid stenting.
And I think it's a little too early for this to show up on the VSITE, where you'd have to know the exact kind of anatomic restrictions with TCAR. You need to have a certain length between the proximal common carotid and the bifurcation. You can't have a calcified, circumferentially calcified carotid because you can't cut down and access it. So there are limitations to the TCAR to keep in mind, and they have to have other anatomic or medical comorbidities that prevent them from undergoing a carotid endarterectomy. Otherwise, it won't be reimbursed, similar to the carotid artery stenting. So more to come on this. It's good to know that it exists and kind of how it fits in, but it's still kind of, its role is still being defined. Okay, so some more carotid artery presentations that we get consulted a lot for. Nicole, what do you do if they say, hey, we got a CTA on a trauma patient with a knee bruise, and we got a head and body CTA, and it shows a occluded carotid artery with, the patient's asymptomatic?
We would just leave that lesion alone and not treat it.
Right. And now, Adam, one thing the VSITE loves to talk about and get into kind of esoteric things is, what if the occluded carotid artery is still causing TIAs on that side? What do you want to consider?
Yeah, so there's some thoughts that the patient might still be having embolization from the either occluded carotid or within the external carotid. And so the treatment for that would be an external carotid endarterectomy and ligation of the internal carotid. Additionally, there's been some data for oral anticoagulation in these patients to further reduce the risk of recurrent stroke.
Okay, so Nicole, what if the patient has severe vertebrobasilar insufficiency and they have carotid artery disease? What would you do to help improve their symptoms?
Well, these patients should undergo a carotid revascularization procedure first to improve cerebral blood flow, and then be reevaluated to see if they're still having symptoms of vertebrobasilar insufficiency.
Right. And so if there's any kind of medical students listening, or people on their vascular rotation, this is one of the few times that you see us operating on carotid disease to improve flow. Almost always when we're operating on carotid disease is to prevent embolic disease. It's never to improve the blood flow. And this is like that one odd situation where you may do a carotid endarterectomy to improve flow if they have concomitant carotid disease and vertebrobasilar disease. So Adam, what about tandem lesions in the carotid? So you have a lesion at the bifurcation that's noted, but you also see, a 60% lesion up in the carotid siphon, which is like high in the, almost in the intracranial portion of the carotid. How would you address this patient?
So the principle behind this is really to treat the carotid bulb first, because this is thought to be the likely embolic source. So treat that and then see if the patient improves.
Yeah, it's not uncommon to see disease throughout the internal carotid, especially as it's making some of the turns going through the intracranial portion. But the carotid bulb is likely, if it meets ultrasound criteria and has the risk factors discussed earlier, then it is likely to be the source of the embolic disease in a symptomatic patient. Okay, as we're getting close to wrapping this up, we'll go through carotid artery dissections. If you're at a trauma center, you probably get consults on these almost daily. So Nicole, can you just take us through the carotid artery dissection and what's our grading system for treating these?
So patients with a carotid artery dissection should initially be treated with antithrombotic therapy, and this can be either an antiplatelet agent or anticoagulation. And if they remain symptomatic with medical therapy, then they can be considered for an intervention. We don't really have great data on what the best intervention for these patients is, but the SVS guidelines, there was sort of an expert consensus that balloon angioplasty and stenting is preferred over carotid endarterectomy for failed medical management in these patients.
Right. And I think, the concern there is getting a good distal endpoint in a patient with a dissection is extremely difficult in the open situation, whereas a stent can really facilitate that. So yeah, these patients, carotid artery dissections, as soon as that they can get anticoagulation, they should. And most people, I think, are just using aspirin. And it depends on the situation that the patient's in and the extent of the dissection and kind of your institutional practices. But antiplatelet or anticoagulation, if they remain symptomatic after that, or they can't be anticoagulated and are symptomatic, that's when you'd consider treating with a stent. Okay. And so, Adam, not an uncommon situation at all, is our patient that has both coronary artery disease and carotid artery disease. I think we get a call about this about once a week from the cardiothoracic service asking us what they should do. How should you approach them on the VSITE?
Yeah, so there's a lot of evidence going back and forth, but it seems there's pretty good consensus that for symptomatic carotid stenosis, and then if they have severe bilateral but asymptomatic carotid stenosis, that they would benefit from a carotid endarterectomy either prior to or at the same time as the CABG, and that the timing of the intervention might depend on the clinical presentation and the institutional experience. And this is grade 1, evidence from the SVS guidelines.
Right. And so what we didn't say in this is all the rest of the patients that just are noted to have a 70% asymptomatic disease on one side, they can get their CABG first and then get their carotid endarterectomy if they qualify and are reevaluated at a later time. So they have to either have symptomatic disease with obvious ultrasound criteria that fit, or they have to have bilateral disease, including stenosis or contralateral occlusion. So all the rest of them should get their CABG first, because as we know, one of the biggest risk factors with patients getting carotid endarterectomies is myocardial infarction after. So having them revascularized from a cardiac standpoint will improve their outcomes from the carotid endarterectomy as long as they're not symptomatic already.
All right. And so then just to wrap up, I know that during our review, we mentioned a lot of different studies, and there's a lot of great literature out there about the carotids. We just wanted to give a brief synopsis at the end about really these are the primary randomized controlled trials that particularly in the United States, all trainees should know and have read and be very familiar with the data, the limitations. So the first is the ACAS study. We're going to have a link in our show notes, but it compared medical management to CEA in asymptomatic patients with greater than 60% stenosis. It found that the 5-year stroke and death rate was 5% versus 11% for just medical therapy. And so, but this was in the pre-statin and the Plavix era, so it's important to be aware of that when you read that. And then the NASIT study that's which will also have a link in our show notes. It compared medical management and CEA for symptomatic patients with moderate and severe stenosis, and it found a rate of stroke at 18 months to be 7% in the surgical arm, but 24% in the medical arm, and an overall risk reduction of 29% at 5 years for stroke and death. So I think that's important to know. These two studies, ACAS is for asymptomatic patients, NASIT was for symptomatic. There are kind of European equivalents. The ACST is a kind of equivalent to the ACAS, and the ECST study for the NASIT. But in the United States, we seem to look to our own literature for kind of guiding principles on these.
In addition to ACAS and NASIT, another important study to be familiar with is the CREST study. And this was a randomized controlled trial that compared carotid endarterectomy versus carotid stenting in both symptomatic and asymptomatic patients. Their endpoint was a composite of 30-day stroke, MI, and death, and they found that this endpoint was equivalent between endarterectomy and stenting. However, when you break it down by those individual endpoints, carotid artery stenting had a significantly higher incidence of stroke and death than did carotid endarterectomy, whereas carotid endarterectomy had a significantly higher incidence of MI. And there have been interesting sub-analyses of the data as well that looked at patients stratified by age and found that older patients actually had better outcomes with endarterectomy than with stenting. And we'll put a link in our show notes to all of these studies so that you can look at them in more detail and familiarize yourself with them.
You know, the SVS has great guidelines, and a lot of this data came from the updated Society for Vascular Surgery guidelines for management of extracranial carotid disease. We'll have a link in our show notes, and that's a highly recommended read for all vascular trainees, and really was the basis for a lot of the data we have here. So we want to thank everyone for joining us today. Thanks to Nicole and to Kevin, and good luck in your studying.
And we are Audible Bleeding, the vascular surgery podcast. You can find us on social media at Audible Bleeding or online at audiblebleeding.com.